Dear doctors, welcome to my channel. I am Dr. Sathkumar, a consultant in internal medicine. We'll talk about how to approach giant cell arteritis. This is a super important topic for MRCP PACES, MD and MRCP Part 2, and other postgraduate exams in internal medicine. This summary is more than enough to bat the exam. Giant cell arteritis. Temporal arteritis. Differential diagnoses. 1. Acute angle closure glaucoma. 2. Granulomatosis with polyangiitis. 3. Herpes zoster. 4. Iritis and uveitis. 5. Migraine headache. 6. Non-arteritic ischemic optic neuropathy. 7. Polymyalgia rheumatica. 8. Postherpetic neuralgia. 9. Retinal artery occlusion, RAO. 1/0 retinal vein occlusion, RVO. 11. Rheumatoid arthritis, RA. 12. Transient ischemic attack. Giant cell arteritis. Temporal arteritis. Important symptoms and signs. A systemic inflammatory vasculitis of unknown etiology. The most common form of systemic vasculitis in elderly age greater than 50 years and female sex are established risk factors. Women, men ratio of 2 to 1. Visual disturbances. Sudden visual loss. Headache throbbing and continuous. Jaw claudication. Neck pain. Scalp tenderness. Constitutional manifestations, such as fatigue, malaise, and fever. Tongue claudication and necrosis. Polymyalgia rheumatica present in 58%. Prominent temporal arteries. Tender temporal area. How to investigate. 1. The laboratory hallmarks of GCA include 2. Elevation in ESR greater than 50 mm per hour. 3. Elevation CRP level. 4. Thrombocytosis. 5. Superficial temporal artery biopsy TAB is the criterion standard for diagnosing temporal arteritis. 6. Color duplex ultrasonography of the temporal artery has emerged as a promising alternative or complement to TAB. 7. Angiography is not the procedure of choice in such cases of GCA. Management. 1. The universally accepted treatment of giant cell arteritis, GCA, is high-dose corticosteroid therapy. 2. High-dose prednisone, 1 mg per kilogram per day, must be started as soon as the diagnosis is suspected to prevent irreversible blindness secondary to ophthalmic artery occlusion. 3. Immediate ophthalmology consultation is a must. 4. High-dose steroid therapy should be maintained only long enough for symptoms to resolve. Steroids then be tapered slowly to the lowest dose required to suppress symptoms. 5. Injections of tocilizumab may also be used.